In this video, we are going to discuss about mitral valve prolapse and hypertrophic obstructive cardiomyopathy. So, mitral valve prolapse, it is the systolic displacement of one or both mitral valve leaflets more than 2 mm beyond the plane of mitral annulus into the left atrium, and it is usually assessed by echocardiography. So, the leaflet bulges or prolapses into the left atrium during systole, and it causes a mid-systolic leak plus or minus late systolic MR murmur. So in mitral valve prolapse, most commonly involved with posterior mitral leaflet. So the excess tissue bulging into the left atrium or the redundant valve tissue which bulges into the left atrium, it pulls the chorda tendine with it, which in turn pulls the papillary muscle that leads to stretching of the left ventricular myocardium, which in the long term can lead to ischemia of the myocardium, and it presents with chest pain, palpitation and syncope just like MI. So here you can see this is the normal mitral valve attached to the chorda tendine, which is attached to papillary muscle. But in case of mitral valve prolapse, most commonly involved with posterior mitral leaflet with ventricular systole, it bulges into the left atrium, which in turn pulls these chorda tendine with it, which pulls the papillary muscles that leads to ischemia and necrosis on the left ventricle, to which the papillary muscles are attached, and it presents with chest pain, palpitation and syncope. So it is associated with glycosaminoglycan deposition in the chorda tendine or in the annulus. If there is GAG deposition in the annulus, there will be annular dilatation and calcification, which can lead to MR. And if it is in the chorda tendine, it can lead to chordal rupture and presents with acute MR. So on auscultation in mitral valve prolapse, we hear a non-ejection click due to sudden stretching of the cords and a murmur which is mid-systolic crescendo decrescendo murmur. A non-ejection click and a murmur that is mid-systolic crescendo decrescendo murmur. It is based on the apex. It is high-pitched radiation. Anterior mitral leaflet prolapse reduces to axilla. If there is prolapse of anterior mitral leaflet, then it reduces to axilla. If there is posterior mitral leaflet prolapse, then it reduces to aortic area. So on dynamic auscultation, Valsalva or sudden staging, there will be decrease in preload, decreased blood in the left ventricle, decreased cavity size, there will be kinking of the chorda tendine, there will be less stretching. Then when the ventricle will now contract during systole, so there will be more prolapse. So click more closer to S1, longer duration of the murmur and loud murmur. We will discuss about that. So this is the mid-systolic, this is the systole, this is the mid-systolic crescendo decrescendo murmur. You can see crescendo decrescendo murmur, mid-systolic crescendo decrescendo murmur. Based order at the apex, it is high-pitched murmur. If the anterior mitral leaflet is prolapsed, then it radiates to axilla. If the posterior mitral leaflet is prolapsed, then it radiates to aortic area. So here you can see this is S1, S2, and this is the systole, this is the diastole. Here the ejection click. Ejection click is due to high pressure opening of semilunar valves, and non-ejection click is due to mitral valve prolapse. Non-ejection click is also known as mid-systolic click because it is located at the mid of the systole. Now there is S2 opening snap. Opening snap is due to opening of mitral and tricuspid valve. So between S1 and S2 or between systole, we have ejection click and non-ejection click. Ejection click is due to high pressure opening of aortic and pulmonary valve. It is heard in case of AS and PS, and non-ejection click or mid-systolic click is heard in case of mitral valve prolapse. So let's discuss about the dynamic auscultation part. So this is the most important part. So in case of Valsalva maneuver or sudden standing, there will be decreased blood inside the left ventricle. When there is decreased blood inside the left ventricle, the cavity size will be decreased. So when the cavity size will be decreased, there will be kinking of this chorda tendine and papillary muscle. When there is kinking of chorda tendine and papillary muscle, or the less stretching of this chorda tendine and papillary muscle, now this valve can move more easily because there is kinking. The valve can move when the ventricle is contracting. So there is less stretching or kinking of the chorda tendine. When there will be contraction of this ventricle, there will be more prolapse of these valves. So there will be more prolapse, which will lead to increase in murmur intensity. Basically in the mitral valve prolapse, there is increase in duration of murmur. intensity also increases, but more importantly duration is prolonged. But in case of HOCM, intensity is prolonged or the murmur is loud, duration is not changed as much. But in case of mitral valve prolapse, duration is most commonly affected as compared to intensity of murmur. But you can explain it like this only: if there is less blood inside the left ventricle, there will be more kinking of the chordae tendineae that will keep this mitral valve leaflets relaxed. When this ventricle will contract, they will move and it will create a sound, or they will move for a longer period of time, that will lead to increase in intensity of the murmur. So murmur intensity increases. The intensity may increase, but the most characteristic change in each earlier onset and increased duration. I told you in mitral valve prolapse, the duration and of mitral this murmur is prolonged and it is earlier onset. On the other hand, if there is squatting or passively aggressive test, then there will be increase volume inside the left ventricle. When there is more volume inside the left ventricle, it will cause stretching of the left ventricular wall. On the left ventricular wall is stretching, the chordae tendon or the papillary muscle, it will also stretch, they will become tight. So increased stretching of the ventricle. When there is more blood inside the left ventricle, there will be increased stretching of the ventricles, and the cavity size is increasing. The chordae and papillary muscle become tight. Now the chordae and papillary muscle become tight, so the mitral leaflet also become tight. So it will less likely prolapse when the ventricle will contract now. So prolapse is decreased, the murmur intensity is decreased. So remember, as general rule, in mitral valve prolapse, when there is less blood inside the ventricle, then there will be murmur will be prolonged, the duration of murmuring will increase. Or when there is more blood inside the left ventricle, the murmur duration will decrease. So this is what happens. Squatting, increase venous return, increase systemic vascular resistance, there will be increase in left ventricular volume. A larger left ventricle keeps the mitral leaflets relatively better supported, so prolapse occurs later. So larger left ventricle, the chorda will be tight, the mitral valve leaflets will be better supported, so the prolapse occurs later. The mid systolic click moves later, murmur starts later and becomes shorter, murmur intensity usually decreases. So this is the normal murmur, that is the mid systolic crescendo decrescendo murmur or non-ejection click. So on Valsalva or sudden standing, there will be decreased blood inside the left ventricle. When there is decreased blood inside the left ventricle, that will lead to earlier click and murmur start earlier, because mitral valve prolapse occurs earlier. When there is decreased LV volume, mitral valve prolapse occurs earlier click, and murmur starts earlier, and murmur lasts longer. The duration of murmur is, here you can see, is increased, and it is starting earlier, it is moving close to S1. So the mid ejection click or non-ejection click on Valsalva or sudden standing, the mid ejection click or the non-ejection click moves more closer to S1, that will lead to longer duration of the murmur on Valsalva or sudden standing. On the contrary, when there will be squatting, there will be increased venous return, or the left ventricular volume is increasing, that will move the non-ejection click or mid systolic click far away from S1, and the murmur duration is shortened. So on squatting or passive leg raise, the murmur duration is shortened. On the other hand, on Valsalva or squatting, the mitral valve prolapse murmur duration is prolonged. So in mitral valve prolapse on Valsalva or standing, there will be decrease in left ventricular volume, causing the click to occur earlier, and the MR murmur start earlier and last longer. The intensity may increase, but the timing is important here. The timing duration is the key point. But in case of HOCM, there will be decrease in LV volume, increases LV outflow obstruction, the murmur becomes louder, and intensity. So MVP is duration is prolonged, and HOCM intensity is prolonged on Valsalva maneuver. On squatting, MVP duration is reduced, HOCM intensity is reduced. So On squatting or passive leg rest test or standing to supine or isometric exercises, there will be increase in preload, increase blood in the ventricle, increase in cavity size, more stretching of the chordae tendineae, pull back of the valve from the prolapse, then there will be less prolapse, clicks moves away from S1, there will be shorter murmur. So this is the mid-systolic click or non-ejection click. It moves away from the S1 during squatting or passive leg, all the things which increases the left ventricular volume. So while the left ventricular volume is increasing, the mid-systolic click is moving away from S1. When left ventricular volume is decreasing, the mid-systolic click is moving closer to S1. So this is the key point here. Now in HOCM, we found a phenomenon that is called Brokenberg phenomenon. On normal heart, when there will be premature ventricular contraction, it will be followed by a compensatory pause. So this compensatory pause gives adequate time for filling of the ventricle. So the ventricle fills more with blood after the premature ventricular contraction. During the compensatory pause, the ventricle fills more with blood. So on the next beat, heart has more blood to pump. So when there will be a premature ventricular contraction, it will be followed by a compensatory pause. During this compensatory pause, heart gets more time to get filled. So the heart is filled with more blood. Now it has more blood to pump. So when it is contract more strongly, as like in Frank Starling law, when there will be more stretching of the valves, then there will be more contraction. So following the premature ventricular contraction, during the compensatory pause, heart is filled with more blood because it getting more time to getting filled. So it is gets filled with more blood. That will cause stretching of the myocardium, that will cause stronger contraction of the ventricle, that will lead to more blood ejection into the aorta, and the aortic pressure will rise. So after a premature ventricular contraction, aortic pressure rises or systolic blood pressure rises. But in case of HOCM, this phenomenon is not seen. This is called Brokenberg phenomenon. So after a premature ventricular contraction, the next beat has more blood to pump, so it contracts more strongly. Now the stronger contraction pulls the mitral valve and the thicker septum together even more, making the obstruction worse. So this is a normal heart. In this normal heart, following a premature ventricular contraction, there will be more cardiac output. But in case of HOCM, when this ventricle is filled with more blood, so according to Frank Starling law, it will contract more. When this ventricle will contract, then this septum and this anterior mitral leaflet, they will, when the ventricle will contract, they both of them will move closer to each other. That will lead to more obstruction of the left ventricular outflow tract, and it will lead to decrease in cardiac output or decrease in stroke volume. So instead of ejecting more blood, much force is spent, lead to creating this obstruction. So less blood reaches the aorta. Here you can see a video of this only. So here you can see when there is a contraction of the left ventricle, the left ventricular outflow tract is more obstructed. You can see contraction of the left ventricle leads to more obstruction of the left ventricular outflow tract. So the contraction of left ventricle is leading to obstruction of left ventricular outflow tract. So this is what happens in case of hypertrophic cardiomyopathy. So it is called systolic motion of anterior leaflet, systolic motion of anterior leaflet or SAM. When there will be following a premature ventricular contraction, there will be a compensatory pause. So during the compensatory pause, there will be more filling of the left ventricle. When the left ventricle is more filled, the valve will stretch more. When the valve will stretch more, so according to Frank Starling law, it has to contract with more speed. When this left ventricle will contract, then that will lead to worsening of left ventricular outflow tract obstruction, because the septum and the anterior mitral leaflet, they come together and they cause the obstruction of the left ventricular outflow, which leads to decrease in cardiac output after a premature ventricular complex. So this is called Brokenberg phenomenon. It is seen in case of hypertrophic cardiomyopathy. So as a result, left ventricular pressure is rising due to filling of blood during the compensatory pause. So ventricle squeezes hard against the obstruction, and that will lead to ventricle squeezes hard against obstruction, but the anterior leaflet of mitral valve and the septum, they come together and they even create more obstruction. That will lead to decreased cardiac output. The aortic pressure will fall, so less blood gets out. There will be decrease in systolic blood pressure, so pulse pressure is decreased. Pulse pressure is systolic minus diastolic blood pressure. So following a premature ventricular contraction, normally blood pressure is increased, but in case of a hypertrophic cardiomyopathy, due to decrease in systolic blood pressure, the pulse pressure will decrease following a premature ventricular contraction. This is called Brokenberg phenomenon. This paradoxical fall in aortic pressure after a premature ventricular contraction is called Brokenberg phenomenon. So HOCM. So HOCM, there will be diastolic dysfunction, the concentric LV hypertrophy, that in expense of decreased cavity size, it will lead to increase in left ventricular end diastole, because the ventricle is becoming steep, it is leading to diastolic failure. So there will be increase in left ventricular end diastolic pressure, which will lead to increase in left atrial pressure, which will lead to increase in pulmonary capillary wedge pressure, which can lead to pulmonary edema or dyspnea or congestion in the lungs. So atrial stretch and dilatation, and there will be risk of atrial fibrillation when the atria will pump against the stiff ventricle. There will be increased pressure inside the atria, so in the long run there will be atrial stretching and atrial dilatation, which makes the atria prone to develop atrial fibrillation. So another thing we see in case of this hypertrophic cardiomyopathy is asymmetrical hypertrophy. So asymmetrical hypertrophy, why? Because it involves only the left side, and there will be septal and anterior wall hypertrophy, sparing the apex and posterior wall. The posterior wall and the apex is spared. The only hypertrophy or asymmetrical hypertrophy seen in the septum and anterior wall. Most commonly it is seen in the septum. So there will be angina also, risk of angina developing in case of hypertrophy of obstructive cardiomyopathy. So due to asymmetrical septal hypertrophy, so here you can see it is hypertrophy of septum, but it is asymmetrical. So asymmetrical septal hypertrophy, it projects into the left ventricular outflow tract. So this is the left ventricular outflow tract. This is the left ventricular outflow tract. Now this asymmetrical septal hypertrophy is projecting into the left ventricular outflow tract. It causes left ventricular outflow tract obstruction. So blood passes rapidly through this narrowed alveoli. When the blood passes rapidly through this narrowed alveoli, so rapid flow across the left ventricular outflow tract creates a low pressure zone. So this low pressure zone pulls the anterior mitral leaflet. So this low pressure zone is pulling the anterior mitral leaflet. So this is the anterior mitral leaflet which is getting pulled. So this is the anterior mitral leaflet which is getting pulled due to the low pressure zone created across the alveoli. So anterior mitral leaflet is getting pulled towards the septum. That is called systolic anterior motion of the leaflet. So systolic anterior motion of the leaflet, the anterior mitral leaflet is pulled towards the left ventricular outflow tract. So both this asymmetrical septal hypertrophy and the anterior leaflet of mitral valve, they will cause the left ventricular outflow tract obstruction. Here you can see in this video also I have discussed earlier. So there will be left ventricular outflow tract obstruction when there will be systolic anterior motion of the mitral leaflet, and this mitral leaflet and the asymmetric hypertrophied interventricular septum, they will both contribute to left ventricular outflow tract obstruction. So systolic motion of anterior leaflet or SAM occurs after 2/3 of systole. So after 2/3 of systole, the systolic motion of anterior leaflet is seen. So that will lead to increased obstruction of left ventricular outflow tract. That will lead to ejection systolic murmur at lower left sternal border. So this obstruction of LVO2 will lead to ejection systolic murmur at lower left sternal border, and if here there will be development of secondary MR. Here there will be development. Now this valve is moving like this. There will be secondary MR. So pan-systolic murmur at the apex can be heard. So what type of murmurs can be heard in HOCM? One is due to obstruction of LVO2, that is ejection systolic murmur at lower left sternal border. Second is due to secondary MR development, that is pan-systolic murmur at apex or mitral area.